Really informative and very nice. And so the next talk is by Dr. Bhavana Khan, rheumatologist at the IRAN clinic.
Thank you. Good morning, everyone. Thank you so much, Dr. Srikumar, for having me here. What an amazing morning. I'm highly impressed with all the talks, and I've definitely taken something in for myself personally as well, and the team of yoga teachers here. So the next part is a bit scientific, which most of our patients don't like to hear. Everybody wants to hear about yoga, everybody wants to hear about stress management. These are the buzzwords these days, diet and everything. But the reality is that we can't shy away from scientific matter. And I think we're all intelligent people, educated people. We always go to the wrong sources to get the right, the scientific material. So I think in the next, I guess I have about 15 minutes. I know we are running over time, but 15 minutes I'll try and just minimize. But what I really want is interaction. I think everybody there is quiet. I haven't heard anybody talk. So can we have more interactions? Because otherwise it just becomes a lecture like all of us have had and fallen asleep. I've got some slides, but these are really the anchor slides, and I'm not going to read out of it. But let's make it more interactive so we understand what exactly you understand by your condition and what questions you have about the treatments and all of that. So what I'm going to focus today is about the arthritis aspect of psoriasis. So I assume many people who are here this morning they're diagnosed with a skin condition called psoriasis, and you know all about it. But I want to sort of take you through what exactly the psoriasis is associated with, and how many of us are aware of that. So how do we progress these slides? Just this way? Okay, now, when we say the word arthritis, what comes to our mind? I know what exactly patients ask me, when I say you possibly have psoriatic arthritis. The first question that comes to many people's mind, but I'm young doctor, I'm only 30 or 40. Why should I have arthritis? Some people say, but I'm very healthy. I exercise very well, and I eat the right kind of diet. So why should I get arthritis? So what exactly do you understand by arthritis? Can I have somebody replying from, okay, yourself? Yeah. What do you think of arthritis?
I think it has something to do with the malfunction of the bones, something like that. Like
Okay.
it's not working well.
Yeah, very close, yeah. So arthritis literally means, this is a term, arthritis is split into two words, arth and itis. So arth is joint and itis is inflammation. So inflammation of the joint is arthritis. It doesn't necessarily involve only bone. There are many structures around the joint. We know that there are cartilages, there are ligaments, and you know that there's a covering of the joint called synovium, which is probably not many people's familiar word, but all these structures can be affected. So psoriatic arthritis is simply joint inflammation in a person who's known to have cutaneous psoriasis or skin psoriasis. They're all quite, interrelated. Now, there is huge amount of research that has gone into this field, because what we understood before, that skin psoriasis is an inflammation of the skin, leading to patches, red patches, scaly skin, because it is an autoimmune condition, or it is because your immune system is dysregulated, or it is rebellious, as somebody used that word rightly, that your immune cells, instead of supporting or protecting your body, they're actually rebelling. They're attacking your own body structures, and one of them is skin. So that is psoriasis. But for a long period of time, people didn't know that arthritis can be, or inflammation of the joints can be related to psoriasis. And we still see some people who have skin conditions but never get arthritis. We also see people, very small number of people, who have psoriatic arthritis without skin problems at all. So it's now we understand it's a much more intricate, complicated immune system, condition. So the term we use now is spondyloarthritis. It's a family of conditions, or it's a group of conditions called spondyloarthritis that encompasses all these different conditions. Psoriatic arthritis is one of that. reactive arthritis. I mean, if you're familiar with this word, that's fine, but they're all various different presentations of the same underlying problem with your immune system, okay? So in other words, a long-standing, chronic simply means a long-standing inflammation of the joints, which is associated with skin psoriasis, usually with psoriasis, but sometimes you may have no psoriasis as well. And usually in these people, the blood tests are typically negative for rheumatoid arthritis. How many of us are familiar with rheumatoid arthritis here? Have we heard of a condition called rheumatoid arthritis? Yes. We know that, there are certain common understanding about rheumatoid arthritis. It commonly affects young people. It affects women more than men. So people are familiar with rheumatoid arthritis. So psoriatic arthritis can be similar to that. The difference is you don't find any antibodies or any positive blood test reports. So quite often, again, I see people come with psoriatic arthritis, not diagnosed previously, even though they've seen many doctors. Why? Because yes, I've had joint problems, I've seen several doctors, they've done blood tests, but my tests were all negative. So arthritis was ruled out, which is a myth. Because typically in psoriatic arthritis, you may not get any positive, tests. And ankylosing spondylitis is quite closely related to psoriatic arthritis. Is anyone familiar with ankylosing spondylitis here? Yeah. So this is basically spondylitis as in back, your spine bones, and there can be inflammation in the spine bones. So that can be one of this. So the word we use is spondyloarthritis or SPA as a abbreviation, and they all fall under the category of seronegative arthritis, which means your serum or a blood sample is negative for all the antibodies you typically see in various different forms of arthritis. So it's negative blood test, but you still have inflammation in the joints. And if you happen to have a skin condition called psoriasis, this is then diagnosed as psoriatic arthritis. It's really important to understand this. I'm emphasizing more on that because the more number of patients we see with psoriatic arthritis usually would have had the condition for at least a year or two. And quite often the diagnosis is missed because their skin may be very quiet. They may not be visiting dermatologists very often because the skin is controlled and they develop a joint problem and they don't necessarily correlate them too. So they think, we always have any excuse to blame your back pain, or you may have some sort of an injury to blame your knee pain or ankle pain. So it's very important to understand that, okay? So going to the next one, again, as I said, rheumatoid arthritis commonly affects women, but in psoriatic arthritis, there seems to be no gender, predominance. Men and women can be equally affected. Again, ankylosing spondylitis, which is commonly seen in men, the myth is the women don't get affected, So I've seen several women who come with spondylitis and psoriasis, having seen certain other doctors and say, oh, you can't have ankylosing spondylitis because you're a lady, you're a woman. So it's only a disease of the men. So they are two wrong things, okay? So spine can be affected in psoriasis. So any back pain, you need to be aware of that. This could be possibly linked with psoriasis. Again, I don't want you to panic because we all have back pain for various things. I don't want to be seeing, hundreds of people with back pain. We all have back pain. And as you all rightly mentioned, it's posture, it's lack of exercise, it's poor ergonomics at workplace. All of them can lead to back pain. But there are certain symptoms that you need to be aware, which can indicate that this could be related to your psoriasis. So that I'll see it in the next few slides. Now, as I said, about 70% of people with psoriatic arthritis get skin involvement first. So people who have skin psoriasis, getting a joint problem, it's easy to diagnose. But about 15% of people, you can get arthritis first and the skin involvement can happen later, or they may never get any skin problem at all. And in about 15%, it can occur simultaneously, okay? What are the risk factors? Some people with skin psoriasis have nail involvement, predominantly nail involvement. You may not have skin problems. So, and I'm sure Dr. Srikumar will agree that these are people who ignore these nail changes and don't even go to see a dermatologist, unless it's a lady who is more worried about her, the skin more from the cosmetic point of view. But many people don't even know that they have psoriasis and just come for joint problems. And when we're examining them, the nail is always the first thing we look at. Your hand examination. Hand is a mirror of your body. So we get a lot of information by hand examination. Sometimes people come with knee problems or foot problem, and you look at their hands, they say, I don't have a problem with my hands, but yes, you can pick up psoriasis of the nails, and many times they would have never seen a dermatologist before. So people who have nail changes, they may be more prone to get psoriatic arthritis. Okay, family history of psoriasis. Again, many times there are seronegative, seronegative arthritis with no skin psoriasis, but there is a family member within the first degree relatives. So and sometimes even a distant relative, second degree relatives also can have a family history. So again, this is a part of our history taking. When people come with joint problems, we always ask for, do you have any skin problems? Do you have psoriasis? Do you have a family person with psoriasis? So these all give us a little clue to find out if they have. And as you rightly mentioned, high BMI, one of the highest risk factors for developing psoriatic arthritis. And we know all the contributing factors. So as you rightly said, watching your diet, how does it help reduce the risk of psoriatic arthritis? Especially if you know you're suffering from skin psoriasis, maintaining your BMI is absolutely vital. So that is one of the independent risk factors. And as you rightly said, these are all part of the metabolic syndrome. So high BMI itself is one of the cardiovascular risk factors. And on top of that, you have skin psoriasis or psoriatic arthritis. It doubles and triples the risk of cardiovascular disease. So BMI is a very important thing. And again, people who have more psoriasis affecting the genital areas are supposed to get higher risk of joint involvement. And as I mentioned, blood tests are generally negative, but sometimes you may find 10% of people having rheumatoid factor. We know that even people without rheumatoid arthritis can have a positive rheumatoid antibody, so you can get that. We've seen sometimes people having skin psoriasis and rheumatoid arthritis as well. It's just the pattern of joint involvement that differentiates between rheumatoid and psoriatic arthritis. Okay, and what causes it? As we've discussed that before. Genetic. I think this is one of the most important factors in people developing psoriasis. So some people are extremely healthy, eating healthy diet, exercising regularly, managing their stress, but they still can get psoriatic arthritis because they're genetically predisposed. So this is something you cannot change, but what you can change is your lifestyle. And it's always people who have a genetic susceptibility or genetically, if they're prone and you have all this imbalance in your lifestyle, poor diet, high BMI, lack of exercise, injuries, all of them can work as triggers. So you have these environmental factors in a genetically susceptible person that leads to arthritis. And you have other immunological factors as well, so we're not going to go into the details of that. So more than 40% of people have at least one first degree relative with either psoriasis or psoriatic arthritis, or one of those other spa features that I mentioned earlier. They could have an eye problem, which is called uveitis, the eye inflammation. They could have bowel inflammation. So if you carefully take a history and start talking to people about their other family members, usually they all come back, they kind of link to each other. And there's a gene called HLA-B27. We often check that. This is, in a person with joint problems we think are inflamed, then a positive HLA-B27 actually gives us a lot more information. But bear in mind, this is not a screening test. Many times patients who have either ankylosing spondylitis or sacroiliitis or psoriatic arthritis, if they have a positive gene, they often come back and ask this two questions. Can my children get this? That's the biggest worry most of people have. And should we be testing HLA-B27 or genetic test? Answer to both the questions is no, because it's not necessary that children will definitely get it. It's not necessary. And by checking the HLA-B27, children may have the gene, but it's not necessary that they'll develop the disease. So I request people not to do it, because I see a lot of people for consultation. Can you see my child because the test is positive? The gene may be positive. It's that interaction with the environmental factors and your lifestyle factors that will actually result in the disease. So no screening is required, and it's not necessary that everybody will get this. You pass it on to your children. And there are other genes that have been implicated in the condition. So what we believe now is the psoriasis or the psoriatic arthritis, it always starts in a structure called emphysis. It's a new word we are using in terms of psoriatic arthritis, because people with psoriatic arthritis do not necessarily come as psoriatic or arthritis. It may not necessarily be a joint swelling or how typically people have joint problems. They may have pain in the knee, but when you examine, when a physician examines, there may not be inflammation, there may not be swelling. Why? Because we think this condition usually starts where the tendons are attaching to the bone, the ligaments are attaching to the bone, or the muscles are attaching to the bone. This is called enthesis, which is why, again, this is one of the factors why an early psoriatic arthritis is often missed. And same with the nails as well, where you have a nail psoriasis, that same nail, this lamina, which is the structure, which is, the attachment of the nail to the structure, and the condition may start here, not necessarily in the joint. Your joint may be perfectly normal. So you need to have that high level of suspicion in a person of psoriatic arthritis with a typical history, and we have some advanced techniques now to identify this as early as possible. So we use what is called as ultrasound scan. It's the same scan we use to check your internal organs. We do the joint ultrasound now, and there are some studies that have shown in people who have psoriasis, and even if they don't have symptoms or severe symptoms, just by doing an ultrasound scan, you can actually identify this much before they become symptomatic. So we are having advances in the technology so that we can identify this condition as early as possible. Okay. So I'm not going to go into the details of this. I'm sure Dr. Sri Kumar has kind of educated all our patients about it. But these are the words you'll come across when you start Googling. A lot of people do that. When you have joint problems, you're diagnosed with psoriatic arthritis, the first source of information is always Google, which is wrong. And the minute you start hearing about all these different words, you get overwhelmed. So I would discourage doing that. So psoriatic arthritis is one of the most difficult forms of arthritis to diagnose, unlike many others. Why? Because symptoms can be very vague, and clinically the doctor may not actually find many clinical features that we see in psoriatic arthritis, and there are no blood tests to confirm this, and not everybody's expertise or have experience in scanning, ultrasound. Even our radiologists are not necessarily trained in identifying these early signs of psoriatic arthritis. So it comes in 5 different diverse forms, we call them as. Asymmetrical mono-oligoarthritis. Again, ignore the word. All it means is, you don't necessarily need to have both hands, all the joints, both knees, which typically we see in rheumatoid arthritis. You don't need to have that. Sometimes people present with just 1 or 2 joints that are inflamed, or the tendons and the ligaments are there inflamed. So this is called the asymmetrical. Symmetrical polyarthritis, which means symmetrical joints. Your small joints in this hand, small joints in this hand. They can be swollen, they can be inflamed, they can be painful and stiff. And the DIP joint involvement, which is just the last digit of your finger. You may not have any other joint problem. Where you have a nail psoriasis, just underneath that joint, what you was showing initially to flex and see, that's this joint, the terminal joint or the distal joint. This is the only joint that may be affected. So again, a lot of people ignore that. And axial spondyloarthritis, which means the spine joints may be affected. So one may have just unexplained back pain. It can come as episodes every now and then. And you may not have any other, what we call as peripheral joints, which means your hand and your upper limb and lower limb joints may be completely unaffected, but your spine may be affected. And arthritis mutilans is a very rare form of arthritis. We don't see that anymore these days, thanks to dermatologists who identify this DIP joint very early and refer patients to rheumatologists. So these are the different types of arthritis. Now, what are the symptoms of psoriatic arthritis? This is the most important part, because again, we don't want to panic. Every joint pain in a person with psoriasis is not arthritis. These could be lifestyle related, these could be mechanical joint problems. So what is the first sign? Swelling of the joints. Any joint that gets swollen, whether it is your knee, whether it is your ankle, or your toes, or your fingers, unexplained joint swelling, which means you've not tripped, you've not had any injury, but your joint has swollen. And if it remains consistently swollen or painful over a period of time. We all have aches and pains here and there, and they come and they go away. But if they are persistent, then that is something it should raise a suspicion to visit a doctor. The second important sign, most of our joints, if you have a problem in your joints, they would hurt when you're walking or when you're using the joint. So if you're walking, your knees start hurting, your back hurts, you've lifted something, you've been up all day. That is called mechanical pain. And these joint pains are usually worse throughout the day and get worse in the evening. But once you've had a good restful night and you wake up in the morning, they disappear. I'm fine in the morning. but as the day goes on and I get on with my day-to-day activities, the pain gets worse. That is a mechanical pain. On the contrary, any joint that is inflamed is always worse first thing in the morning. When you wake up, you should be refreshed, you've had sleep, you've rested your joints. But a joint that is worse or more painful on prolonged rest, okay? This is a typical symptom of an inflamed joint, whether it is psoriatic or rheumatoid or any joint, okay? And likewise, back pain that is stiff, that is worse in the mornings when you wake up. So it's called morning stiffness or early morning stiffness. The typical history is, I go to bed with pain and I wake up in the middle of the night and I'm extremely stiff. I'm unable to turn sides. And first thing in the morning when I wake up, I'm like an old person. I'm bent. I'm not able to straighten up. And this can take up to 1 hour or 2 hours that stiffness can last. But the minute I start walking around, my stiffness is gone. The more mobile I am, the better I am. So this is inflammation. So that is another symptom. So swollen joint, which is unexplained without any injury, and if it feels warm or hot, and it persists for over a period of time, that's one symptom. The second symptom is stiffness that is worse in the mornings and gets better with activity. That's the second symptom. So these are some of the signs and symptoms you need to be aware of. And not every pain is psoriatic arthritis. So again and again, I emphasize on that, okay? Again, I don't intend to cause any inconvenience to people who have this, but this is just for your knowledge. You can see that this person has nail changes of psoriasis, but if you carefully see, the distal joint is swollen there. The distal joint is swollen here. Also, if you see this joint compared to this joint is a bit swollen. These could be very, very early symptoms and signs of psoriatic arthritis. So these are things that one should not ignore. And again, this is in the foot. Compared to the normal toe, and these two joints are swollen. This is called dactylitis or a sausage digit. That's the name because it looks like sausage. It's swollen because not just the joint is swollen, but also the tendon, the skin, the subcutaneous or the tissue under the skin, they're all swollen. So this is called dactylitis. One other important feature of psoriatic arthritis is enthesitis, as we saw earlier. Now there are certain enthesial sites that are commonly affected. Heel pains and the ankle pains. Again, heel pains is very common. We wake up in the morning, feel a bit of heel pain, but once you're up and about, it gets better. Achilles tendon, the back of your heel, there is a tendon from the calf muscle, that attaches to the heel bone. That is called Achilles tendon. It's a common site of early inflammation in psoriatic arthritis. You can see that this is swollen. And again, compared to this, you can see that the heel is swollen here. And if you take an X-ray, you can see a spur, which is like an irregularity of the bone. And this could also be one of the symptoms of psoriatic arthritis, or an early symptom or an early sign of psoriatic arthritis. Axial involvement, as I said, the spine joints can be affected. And many times on X-ray, you can see the spurs. The bone gets a little rough and it can start causing a spur. And this is typically where the tendons and the muscles of your back are attached. And this is another form of enthesitis, which if not detected early and not treated early, it can progress to form what's called as bamboo spine, or the bones in the spine can get rigid and one may lose mobility of the lumbar spine or the entire spine. So again, inflammatory back pain, which is worse in the morning when you wake up, gets better with movements and exercise, in a person who has psoriasis should raise a suspicion of psoriatic arthritis or a spondylitis. And do you know what is the best form of treatment for this in the early stage? Not any medication, just stretches, exercises. So 15 to 30 minutes of everyday stretching for your back is one of the best treatments for psoriatic early spondylitis, okay? And I can see that you're very happy to hear that. So there are different areas of inflammation in the joints, which are not the common sites, and again can be easily missed, even by medical professionals. You may go to see a GP or you may go to see orthopedic doctors with pains and symptoms in these areas. Unless you give a very clear history, yes, I do suffer from psoriasis, and I'm just concerned that this could be related to my psoriasis. Unless you give this history, even the orthopedic doctors may not be able to pick that up because it's a very a random symptom that you're giving them. And there are other causes of pains in these areas as well. Like typically, you could get what's called as costochondritis, where your ribs get attached to the bone, the breastbone, and this is one of the common sites of psoriatic arthritis. It's called costochondritis. Many times patients end up having coronary angiogram, thinking that this is a cardiac pain. Because typically chest pain, you're worried about heart attacks, you go to the emergency, you're referred to a cardiologist, and they can't be sure. They take you through the angiogram only to see that your coronaries are all fine. But sometimes, as we discussed, people with psoriasis may have high cholesterol, and you could even see some plaques in the coronary arteries. So there can be small little early blockages, but it can be completely missed. A simple way of finding out whether this is cardiac related pain or your psoriasis related pain. You just have to press the area, and if it is tender, it cannot be a heart related problem, because the joint of the rib is very inflamed. The other thing to find out, take a deep breath and breathe out. So a simple deep breath, you won't be able to do that because the ribs help you expand your chest, when you're doing a normal respiration. If you take a deep breath and if your ribs are inflamed, you won't be able to take a deep breath. The other simple test is, when you're lying on your bed, put your hands across the chest and try to get up. You won't be able to do that. Why? Because the ribs are all inflamed. So costochondritis is one of the common manifestations, okay? So bear in mind that. And sacroiliac joints, these are the joints which people have never heard of. These are your back, the very bottom part of your spine, the joints on which you're sitting. These are the sacroiliac joints. These are one of the first joints to get affected in people with spondylitis. And again, when you have back pain, quite often x-rays are done by your doctors, and this diagnosis is completely missed. Why? Because most of the x-rays are taken only till here. The spine may be x-rayed, but these joints are not included in your x-rays. So it can be completely missed until it kind of progresses to a very later stage. So heels, as I said, knees, and sometimes even bursitis. You must have heard of the word bursitis. They can all be very mild forms of psoriasis, and unless you mention it to your dermatologist who's treating your psoriasis, they may not be able to even refer you to the appropriate doctor, okay? So, what are the diagnostic challenges? We've discussed that already, so I'm not going to go into that. This is one of the very simple forms of early screening questions for people with psoriatic arthritis in a dermatology clinic. We always, in our medical meetings,
all our patients are filled in.
They have done. I know you're spot on, Dr. Sharma. So we always emphasize that because, as we said, even in my clinic, when people come to see me for joints, unless you make an effort to ask them about psoriasis, you may miss the skin condition as well. So we have similar forms in rheumatology where people fill a questionnaire and they always answer the question if you have psoriasis, you have nail problems, etc. So it's very important. Simple 2-minute questionnaire. You leave it in the reception or in your where patients are waiting to see the doctor. They fill this. This is one of the earliest and very, very effective way of screening for arthritis in people with psoriasis. Okay, it's called a PEST screening tool. So that's just a little overview on what is psoriasis, how it can affect joints, how it can affect other organs like eyes, red eyes, painful eyes, blurry vision. Again, if you have psoriasis, always think it could be related to your psoriasis. People who have bowel symptoms, unexplained diarrhea, unexplained weight loss, alternating diarrheas and constipation, blood or mucus in stool, because one could have the colon inflammation as well. So one need to be aware, but there's no need to panic because it's not necessary that if you have psoriasis, you will get the others. No, you may be at a risk, but if you have symptoms, you need to be aware. So treatment of psoriatic arthritis, again, it's a topic in itself for discussion. And again, I'm not going to talk about any drugs or anything today. That's not the purpose of this meeting. But I think what we need to be aware is that there are treatments available. And at every different stage of psoriatic arthritis, there are treatments available appropriate for the extent of joint involvement. But it's important to identify it early because what we call as a window of opportunity is lost. If you leave it for too long and if you leave it until the joints actually get damaged, there is no reversibility. One cannot reverse what's happened. I see a lot of patients who come with arthritis and they have severe psoriasis and they're not bothered so much about their skin. Why? Because they say we can cover it. I know I'll wear a full sleeve shirt. I don't want to take medication for my psoriasis. But as we say, it is only a tip of the iceberg, which means what you're seeing on the skin is only a small aspect of the whole condition, and there are many more things happening, and we need to be vigilant and we need to address that. So treatment obviously is dependent on the diagnosis. Most of the times there is no early diagnosis in people with psoriatic arthritis unless the person is aware and they actually inform their dermatologist or their treating doctors about their symptoms and they make an effort to see the appropriate physician. So diagnosis is always delayed, and it's always one of the biggest challenges we face here. Once the diagnosis of psoriatic arthritis is made, the most important aspect of it is education. And as we said, it's denial. I'm healthy, I eat healthy, I exercise. I should not be having arthritis. I'm only young, so why should I have arthritis? So denial is a big factor here. So education, stepwise education, again bombarding them with a lot of information in the first go. People get very overwhelmed and walk out of your consultation room and never come back to see you again. I think this doctor is talking something stupid. So education plays a very important part. Physical occupational therapy, again, there are people who have a lot of joint limitations, whether it is a very early inflammatory condition or whether it is an advanced arthritis, people have limitations. So occupational therapists can help you a lot because you can have various supporting gadgets nowadays to help open the bottles. These are simple tasks, day-to-day tasks that we have difficulties with. Opening the toothpaste, top, or opening a bottle, even chopping your vegetables, day-to-day work, they can be really effective. Occupational therapists can help you with that. Anti-inflammatories, quite widely used and misused drugs, because again, early psoriatic arthritis, especially if there is only tendon and ligament inflammation, they respond very well to non-steroidal anti-inflammatory drugs. But people get habituated to take them over the counter because here you don't need to buy them. You don't need a doctor to prescribe them, you can buy them over the counter. So a lot of times people just go to chemists or pharmacy and buy them because they feel better. But bear in mind, these are probably long-term the worst drugs to continue taking without consultation because they can damage your kidneys, they can damage your liver, they can damage the lining of your stomach, and they can cause cardiovascular problems. So it's very important that you minimize the use of anti-inflammatories. They're great drugs when you're in pain. They're great drugs when you have acute inflammation, but limit the use. If you're going to need it on a frequent basis, you may as well consult the doctor and treat the underlying cause, and because these are not really the right kind of medication. Okay, so if you respond to this very well, you continue that and monitor your condition. But you have inadequate response, we now have a huge choice of medication called the disease-modifying anti-rheumatoid drugs. We've borrowed it from the treatment of rheumatoid arthritis, but we know that they work for your skin, they work for your joints, they work for your eyes, and they have common sort of mechanism of action which can actually treat the underlying conditions. So what's the difference between the DMARDs and the NSAIDs? NSAIDs are temporary symptomatic treatment. They may not necessarily modify the underlying immune problem that you have. So these DMARDs are the drugs of choice. And I'm sure even for skin conditions, we use it very often these days, even if you don't have arthritis. But again, not everybody needs them, but it's important to know whether you're the right candidate for these medications. These are simple drugs, they're oral medications, but has to be taken only under supervision. That's why you do not get them over the counter without a doctor's prescription. Some people try and sneak them. Many of our patients just get them from India. It's easily available. It's one of the easiest ways to get. The reason we want to put a regulation on that is because they are actually working on your immune system. So you need to be aware that without the expert monitoring, you have to have a regular blood test, you have to monitor your blood counts, you have to monitor your liver tests. Without that, it's not safe to take them. But there are some people, despite taking disease-modifying agents, your condition may not come under control. Why? Either because you may not be able to tolerate these medicines. Some people may get some physical side effects like nausea, vomiting, hair loss, but not everybody, but some people may not be able to tolerate them. Some people may not respond to them. You take them, but your condition is not getting better. So why take a medication which is not helping you? That's why we have, the newer type of medication called the biologics. Again, a lot of our patients are on biologics, and these are literally the miracle drugs, we call them. But everything comes with a package. You have benefits, you have limitations. You need to be aware of what these limitations are, and again, these have to be taken only under supervision. They're highly expensive, that makes them less popular, but these are one of the best treatments available today for treatments of both psoriasis and psoriatic arthritis. And the good thing is, they control your skin, they control your joints as well. But sometimes we see that, they may work for your skin, but they may not work for your joints. So depending on whichever is the most active component, we kind of then decide who's going to decide on your treatment. So I see a lot of people with mild arthritis, but very severe skin problem, I don't like to treat them. I would like to send them to dermatologists because I don't want to decide on a biologic or a DMARD which would work for skin because I'm not experienced. I don't have that expertise. And likewise, there are people with arthritis which is more active than the skin, and we need to have that combined sort of consultation with the dermatologist. So quickly, that's my last slide. Challenges. I think we can have a debate on this for the whole day. But these are real challenges that come or interfere in effective treatment of both psoriasis and psoriatic arthritis. Delay in referral, I think we face that still. There are very, very few dermatologists, unlike Dr. Sri Kumar, who would just send them to rheumatologist early, either because it's not picked up or because the patients are not educated and they may not inform the doctor that they have a joint problem. And many people don't know who a rheumatologist is. So quite often people with bone and joint problems end up seeing their GPs or orthopedic surgeons. With all due respect, I mean, they all have their own expertise and specialization. But when it comes to psoriatic arthritis, as I said, it's a very, very complex condition. In early condition, you may not get any of the telltale signs. Okay. So maybe it's indicating that I should stop. So I think the delay in diagnosis is one of the major limitations. Let me just get the last slide here.
Maybe
So-
this one.
So that's what leads to delay in diagnosis. And lack of expertise in imaging, as I said, one may have a back pain, may have a consultation with an orthopedic doctor or even a rheumatologist for that matter, and you get an X-ray or an MRI scan, but a radiologist doesn't pick up. It comes back as a normal X-ray or a normal MRI scan. So there can be a delay. You can just leave that one. I can talk on that. So lack of expertise in radiology, that's one of the other issues. And insurance problems, we all face that, and thanks to our Axios team and similar patient support teams, we are having less and less of these problems, but we still have difficulties in getting insurance approval for many of these drugs. I just saw a patient who was a definite eligible candidate for biologics. The insurance policy includes biologic therapy, and the insurance companies now have started this new practice of sending them to a second opinion doctor. And just because the other person feels that they don't need it, or we don't know what dynamics go on there, people have declined. So we are actually battling this insurance issues here. But at the end of the day, it's not the insurance company who's responsible for your health. You yourself are responsible for health. So we need to find the ways in supporting your treatment. And Axios team, and we have some other support programs in this country. To be honest, one of the biggest challenges I face, I don't know about you, Dr. Sri Kumar, but cultural beliefs and alternative therapies, I think is one of the major problems that we have. I don't ever see a person who comes to the clinic and goes out saying, yes, I'm happy to take this medication. There's a huge myth that all drugs are bad. They all give side effects. They're all going to give you more problems than the actual joint or skin problem. Ayurveda is better, homeopathy is better, it can cure, naturopathy is better. I mean, with all due respect, they all have a role in this, and I totally agree with both of you that they are all complementary to each other, which means there are certain conditions where we tell people that, all that you need is lifestyle changes. There is no drug that can cure your problem. On the other hand, there are some conditions where you need interventions. They can be life-saving, they can improve your mobility, and they can improve your quality of life. People have a huge barrier, and especially I think our population from the Far Asian countries, they all believe in traditional methods of treating, especially when it involves long-term treatments. It's a big challenge. So I think these are some of the local barriers that we need to overcome. Compliance, adherence, I totally agree with that, because people often get fed up. How long are we going to take this medication? The first question, we've not even started the treatment, but the first question asked is, how long do I need the treatment for? Wish we had the answers. No, we don't. A lot of research has been done in this field. All we know is people need treatments. We really don't have guidelines to tell us when we can stop these drugs. There are some studies coming up, which is good. A lot of doctors are sort of doing it either out of compulsion because there is nobody to pay for the drugs, or insurance doesn't pay for the drug, we stop them. Sometimes when people are in long-term remission, we stop them. Unlike in dermatology and gastroenterology, there, I think there are more studies to look at when we can stop them. But in rheumatology, people with arthritis, we still do not have clear guidelines as to when to stop the biologics. But we still do that sometimes, when people have been very, stable for many years, we try to wean them off and stop them. The other problem is we do not have, biomarkers. These are called biomarkers or lab tests where we can do a blood test and say, look, you're fine now, we can stop your medication. We don't have them yet. So it's very much tailored to each individual patient's need. So there are some people who are able to come off the biologics. There are some people who need it for many, many years. So it's very difficult. But in this whole journey, the patient compliance, patient adherence is the biggest challenge, because after some time when people feel well, they automatically stop their medication and don't even come back to see you or see any doctor, and only come back when things have gone really far and things have gone really progressed. That's when we see them. And I think what people don't realize is by doing this, you're actually compelling yourself to go back on more and more higher forms of biologics, because it's only going to go into a vicious cycle. But one thing we know is the sooner you diagnose, the earlier you start effective treatment, whether it is DMARDs or whether it is biologics, the more chances of you going into a long-term remission and actually being able to come off medication. The longer you wait to start effective treatments, and the longer you wait until your joints are damaged, there's very little we can do to reverse that. And the longer you end up being on biologics. So I think the compliance is a huge, huge factor here. So I think these are some of the major challenges. They all vary from place to place, country to country. Western countries have different challenges. Here we have different challenges. But overall, I think one thing to bear in mind is, we need to have a very clear plan of a treatment. And if you have any concerns, you must voice it. I mean, no doctor is going to force you to take a treatment, but it's always about mutual discussion and mutual agreement. So that's why, what we have is now clear guidelines about how we treat psoriasis and psoriatic arthritis. It's always a multidisciplinary approach. And as we said, there are multiple domains affected in this: skin, joints, eyes, sometimes colon, sometimes cardiovascular, body weight, So we involve everybody and we work like a multidisciplinary team. That's a very important thing. Shared decision. The more you educate people, the more they feel the need for the medication, the likely they are to take it and be compliant and adherent to it. So this dialogue is very important. So it's a shared decision between the physician and the patient. And we must consider everything. Is this drug going to be efficient? Is that drug safe for you? We may have typically a young lady who wants to conceive and have a family. You can't give her methotrexate. So, this is very important. So you must have a shared decision. Also consider the cost factor. If everybody has to go on biologic, who's going to fund them? So it's only reserved for people who deserve it. So the drugs, the high cost medication, are for people who need it, and people who can manage without biologics, we should not overprescribe them. So that is to be taken into consideration. And there is a general understanding that when people have predominantly joint problems, they must be treated by rheumatologists, because a lot of drugs are common for skin and joints. So sometimes we see that, with just changing the biologic, okay, your joint is going to get better. But there are various ways of assessing if the drug is working or not in the joints, and that's completely different from the skin perspective. So we have a clear understanding: when you have a predominant or active skin component, you go to your dermatologist, they will decide your treatment. But if the joints are affected, then the rheumatologists are in charge. And again, at the end of the day, our primary goal is the same as the patient's primary goal. We want a better quality of life, and that's the ultimate, outcome. And of course, bear in mind that, we have not just the joints and skin, but there are extra articular features, which means other than joints, you have, colon, eyes, and various organs. And the most important thing is the cardiovascular. So how can one justify these extremely expensive drugs is not because, people often ask, I only have a skin problem. Why should I pay, 8,000 dirhams every month to clear my skin? I may as well go to some cosmetologist, or I may as well have some, laser treatment or whatever. It's not just your skin or joints we're worried about. We're worried about your cardiovascular health, because we know that these autoimmune conditions with systemic inflammation, they have a higher cardiovascular mortality. So our ultimate goal is to prevent any secondary cardiovascular risks. So I think that's what I would like to end with, but open to any questions if you have. Thank you. Thanks for listening. Don't know if you have questions or time for questions. We've overrun the time, yeah. Any questions at all? I'm sure Dr. Sri Kumar has answered all of them.
Not like that. Please.
Thank you so much.
Thanks.
I'd like to now invite the CEO of the Amber Clinic, Mr. Stephen Taylor.
Wonderful.
Thank you. Thank you so much. No, but the first is very informative. I really enjoyed this one.
You were hard pressed for time.